Hello friends. Today we are going to discuss about the refeeding syndrome. This was also a question which was asked in DRNB critical care exam. So refeeding syndrome is the critical clinical condition defined by severe metabolic and electrolyte shift that occur when nutrition is rapidly reintroduced after prolonged period of starvation. This syndrome poses the significant risk, particularly in population vulnerable to the malnutrition, such as individuals with the eating disorder and patients undergoing hemodialysis. Pathophysiological hallmark of the refeeding syndrome is hypophosphatemia, though it is often accompanied by the other electrolyte disturbances, including hypomagnesemia, hypokalemia, and thiamine deficiency. This imbalance can lead to life-threatening complications affecting cardiopulmonary, hematologic, and neurological systems. So, etiology of the refeeding syndrome is complex and multifactorial, primarily associated with the metabolic and physiological response to the rapid reintroduction of nutrition after prolonged period of starvation. The key underlying mechanism involves shift in the fluid and electrolyte that occurs when insulin secretion increases in response to carbohydrate intake. This surge in insulin prompts the cellular uptake of glucose along with essential electrolytes such as phosphate, potassium, and magnesium, leading to their depletion into the bloodstream. Consequently, individuals who have been malnourished or in catabolic state are particularly vulnerable to refeeding syndrome upon receiving nutritional support. So, several factors and conditions predispose the individual to the refeeding syndrome. These include eating disorder, like conditions like anorexia nervosa, often involve prolonged period of inadequate nutrition, making rapid refeeding a critical risk. Then chronic alcoholism. Long-term alcohol abuse can lead to poor nutritional intake and deficiencies in essential nutrition, setting stage for the repeating syndrome. Then malabsorption condition. Disorders like inflammatory bowel disorder can impair nutrient absorption, contributing to the malnourished state. Then chronic malnutrition due to various causes, including socio-economic factor, chronic illness, or neglect. Then poorly controlled diabetes. Patient with the severe diabetic complication may experience malnutrition due to poor dietary intake and metabolic disturbance. Then oncological condition. Cancer and its treatment can lead to cachexia and malnutrition. Then post-operative state, especially in patients undergoing major surgery who experience significant stress and altered nutritional intake. Then pathophysiology. Pathophysiology of the refeeding syndrome revolve around the body's metabolic response to the reintroduction of nutrient after a prolonged period of starvation. During starvation, the body undergoes several adaptive processes, including increased gluconeogenesis and proteolysis to maintain energy production. However, this adaptation depletes the metabolic substrate, including essential vitamin and intracellular electrolyte, particularly phosphorus, potassium, and magnesium. Then glucose and insulin dynamics. Upon sudden nutritional replenishment, especially with carbohydrate, there is rapid increase in the blood glucose level. This trigger corresponding increase in insulin secretion, hormone that facilitate glucose uptake by the cell. So the surge in insulin drives the glucose along with potassium and phosphorus into the cells. This shift causes marked decrease in extracellular concentration of this electrolyte, leading to hypokalemia and hypophosphatemia. The reduction in extracellular potassium is partially due to its role in phosphorylation of the glucose during glycolysis and stimulation of sodium potassium ATPase. Now, electrolyte imbalances. So, first is hypokalemia. There will be the significant drop in potassium level that can result in range of complications, including cardiac arrhythmias, muscle weakness, fatigue, paralysis, hypoventilation, metabolic alkalosis. These symptoms can particularly concerning as they lead to severe outcomes such as respiratory distress and cardiac arrest. Then hypophosphatemia. Phosphorus is the crucial for production of adenosine triphosphate and the energy currency of the cell. In state of starvation, phosphorus stores are already depleted and Increased insulin sensitivity during refeeding exacerbate this depletion. So hypophosphatemia can lead to diminished cardiac contractility, arrhythmia, and even cardiac failure. Additionally, the decrease in phosphorus level reduces production of 2,3-DPG, causing leftward shift in the oxygen hemoglobin dissociation curve. This shift in hemoglobin affinity for oxygen, thereby reducing the oxygen release to the tissue, potentially leading to tissue hypoxia and secondary organ failure. Respiratory muscle function can also be compromised, resulting in acute respiratory failure. Then hypomagnesemia. Although less well understood, hypomagnesemia frequently accompanies refeeding syndrome. It may exacerbate other electrolyte imbalances such as hypokalemia by increasing renal potassium wastage. So magnesium is also cofactor in numerous enzymatic processes, including those involved in ATP production. Clinically, hypomagnesemia can manifest as neuromuscular symptoms such as ataxia, vertigo, convulsions, paresthesia, and depression. Then cardiac complication. The combination of hypokalemia and hypomagnesemia can precipitate severe cardiac events such as torsades de pointes, a potentially fatally polymorphic ventricular tachycardia associated with QT interval prolongation. This condition can lead to sudden cardiac arrest if not promptly addressed. Management involves correcting electrolyte imbalances and in some cases administering intravenous magnesium to stabilize cardiac memory. Then thiamine deficiency. Thiamine, that is vitamin B12, is the essential cofactor in carbohydrate metabolism, particularly in the conversion of lactate to pyruvate. During refeeding, the demand for thiamine is increases due to accelerated carbohydrate metabolism. A deficiency in thiamine can lead to accumulation of lactate and subsequent metabolic complications. Neurological manifestation of thiamine deficiency include Wernicke's encephalopathy and Korsakoff syndrome, which is characterized by the symptoms such as memory impairment, ophthalmoplegia, ataxia, and confabulation. In severe cases, thiamine deficiency can also lead to cardiac dysfunction due to impaired ATP production. The risk of thiamine deficiency is heightened in individuals with chronic alcohol use, which can further complicate the clinical presentation of refeeding syndrome. Overall pathophysiological changes in refeeding syndrome underscore the critical need for careful monitoring and gradual nutrition repletion in at-risk individuals to prevent these potentially life-threatening complications. Then history and physical examination. Clinical presentation of refeeding syndrome is varied and often reflects underlying biochemical disturbances caused by rapid shift in electrolytes and nutrients. This shift disrupts the cell membrane potential and cellular function, leading to the ranging multisystem symptoms. Then cardiovascular symptoms. Patient may present with cardiovascular symptoms such as arrhythmia, hypotension, cardiomyopathy, shock, bradycardia, and even cardiac arrest. These manifestations can result from electrolyte imbalances, particularly hypokalemia and hypophosphatemia, which are common in refeeding syndrome. Renal symptoms, renal complication can include acute tubular necrosis, renal failure, and metabolic acidosis. These issues may arise due to alteration in sodium and phosphate balance, further complicating the clinical picture. Respiratory symptoms. Respiratory complications are also common and can include respiratory failure, pulmonary edema, and hypoventilation. These issues may result from diaphragm weakness and reduced muscle strength, which are consequences of electrolyte disturbances. Musculoskeletal syndrome and refeeding syndrome can range from rhabdomyolysis to generalized weakness, myalgia, fatigue, muscle twitching, and diaphragm weakness. These symptoms reflect the profound impact of electrolyte deficiencies, including low level of potassium, phosphate, and magnesium. Then GI symptom. GI symptom often linked to hypokalemia, hypomagnesemia, may include diarrhea, constipation, nausea, vomiting, and paralytic feelings. This symptom can exacerbate patients' discomfort and complicate management. Then comorbidities. Many patients with refeeding syndrome also have comorbid conditions such as electrolyte and vitamin deficiency, which can be further complicated by alcohol use disorder. Alcohol abuse exacerbates deficiencies, particularly thiamine deficiency, leading to more severe manifestations. Now, the evaluation. The evaluation of refeeding syndrome involves comprehensive assessment of both clinical symptoms and lab findings. Due to wide range of symptom and lack of university adapted accepted diagnostic criteria, American Society for Parental and Enteral Nutrition established an interpositional task force to provide consensus on clinical definition and recommendation for refeeding syndrome. So ASPEN characterizes the severity of syndrome into three levels. It is mild, moderate, and severe. Mild is decrease in serum phosphate, potassium, or magnesium level by 10% to 20%. Then moderate, it is a decrease in serum phosphorus, potassium, or magnesium level by 20% to 30%. Then severe is a decrease in serum potassium, phosphorus, potassium, or magnesium level by more than 30% and or organ dysfunction resulting from the deficiencies or due to severe thiamine deficiency occurring within 5 days of reintroduction of the calories. Then treatment and management. The management of refeeding syndrome requires careful and coordinated approach, particularly when initiating nutritional support in individuals who have experienced prolonged period of malnutrition or starvation. The primary goal are to prevent and correct electrolyte imbalances, ensure adequate but gradual nutritional replacement, and monitor for clinical complications. Now, initial assessment and monitor. Screening and risk assessment. High-risk patients, including those with history of eating disorder, chronic alcoholism, malabsorptive condition, or recent significant weight loss, should be identified through thorough screening. These include nutritional assessment and evaluation of baseline level of key electrolytes like phosphate, potassium, magnesium, and thiamine. Then electrolyte monitor. According to ASPEN guideline, it is crucial to check and correct electrolyte level, including magnesium, phosphorus, potassium, before starting nutritional replacement. In high-risk patients, these levels should be monitored every 12 hours for first 3 days and then daily at least first week and as needed thereafter. The NICE guideline provides specific daily replacement recommendation. That is potassium 2 to 4 mmol per kg per day, phosphate 0.3 to 0.6 mmol per kg per day, magnesium 0.2 mmol per kg per day intravenously or zero point 0.4 mmol per kg per day orally. Then nutritional replacement, conservative calorie intake. The initial calorie intake should be conservative to prevent overwhelming the metabolic capacity of the patient. Aspen suggests starting with 100 to 150 gram of dextrose or 10 to 20 kilocal per kg first 24 hours, followed by gradual increase of 33% of target nutritional goal every 1 to 2 days. This gradual approach helps mitigate the risk of rapid shifts in electrolyte and metabolic complications. Then choice of nutritional route. Whenever possible, enteric feeding is preferred over parenteral feeding, especially in clinically ill burnt patients, as it helps maintain gut integrity and immune function. Supplementation with specific nutrients such as glutamine, L-arginine may support immune maintenance and reduce systemic bacteria. Then supplementation and specific nutrient management. Thiamine supplementation. Thiamine deficiency is significant concern in refeeding syndrome due to its role in carbohydrate metabolism. So Aspen recommended as administration of 100 mg of thiamine at least 30 minutes before starting dextrose-based solution and continuing supplementation twice daily for 7 to 10 days. Routine checks for thiamine level may be of limited value, but are important in preventing nutritional complications like wernicke's encephalopathy. Other micronutrient, multivitamin and trace elements should be supplemented as needed to address any other deficiencies that may arise during refeeding process. Now monitoring and adjustment. Vital signs and clinical monitoring. Continuous monitoring of vital signs, including heart rate, blood pressure, respiratory rate, and temperature, is essential, especially in the initial phase of refeeding. Vitals should be checked every 4 hours for first 24 hours after initiating nutritional support. Additionally, daily weights and fluid balance should be closely monitored to detect any signs of fluid overload or other complications. Then adjustment based on clinical status. Nutritional replenishment may be needed to be delayed in patients with severe electrolyte deficiencies, particularly those with critically low level of potassium, phosphate, or magnesium. Nutritional goal and supplementation should be tailored based on ongoing assessment and lab results. Then guideline recommendation. According to ASPEN, emphasize gradual refeeding and close monitoring of electrolyte and clinical status with particular attention to avoiding rapid increase in caloric intake. Then, according to NICE guidelines, stress the importance of formal nutritional assessment and baseline electrolyte evaluation with specific recommendations for daily replenishment target for potassium, phosphate, and magnesium. Now, about differential diagnosis. One differential diagnosis that we can consider is fluid overload. Fluid overload can cause dilutional changes in plasma electrolytes, leading to apparent decrease in sodium, potassium, magnesium, phosphorus. This condition must be differentiated from refeeding syndrome, as both can present with similar biochemical abnormalities but require different management strategies. Then cardiac arrhythmias. Independent cardiac arrhythmia, especially those resulting from electrolyte imbalance, need to be considered. For example, long QT syndrome, which can be exacerbated by hypokalemia and hypomagnesemia, should be ruled out. The presence of arrhythmias may not be necessarily indicating refeeding syndrome and could have other etiologies such as genetic predisposition or medication side effects. Then electrolyte disorder. Primary electrolyte disorders such as hypokalemia, hypophosphatemia, and hypomagnesemia can occur independently of refeeding syndrome and may have different underlying causes. For instance, renal dysfunction, electrolyte losses, or medication effect can lead to electrolyte imbalance that mimic those seen in refeeding syndrome. Thiamine deficiency. While thiamine deficiency can be part of refeeding syndrome, it can also occur independently, particularly in patients with alcohol use disorder. Differentiating isolated thiamine deficiency from the broader syndrome is crucial for appropriate treatment. Then about complication, refeeding syndrome can lead to range of complication due to electrolyte imbalances and metabolic disturbance. Potassium imbalance, hypokalemia can result in cardiac arrhythmia, QT prolongation, muscle weakness, fatigue, paralysis, and respiratory distress. Then phosphorus imbalance. Hypophosphatemia can cause cardiac arrhythmia, decreased production of 2,3-DPG, reduce oxygen delivery to tissue, and decrease respiratory muscle function. Then magnesium imbalance. Hypomagnesemia can lead to neurological symptoms such as ataxia, vertigo, paresthesia, convulsion, depression, and cardiac issues like QT prolongation. Then thiamine deficiency. Thiamine deficiency can result in cardiac dysfunction, neurological syndromes like Wernicke's encephalopathy, Korsakoff syndrome characterized by memory impairment, ophthalmoplegia, ataxia, and confusion. Thank you, friends.